All right, we are recording. All right, so where are we? Before we get started, last week we kind of didn't get to totally finish EKGs. And so I just want to do a little bit of review and kind of go over some of the EKG with you because I feel like you guys did a really good job of learning how to measure, to see if things are regular versus irregular. But I want to give us a little bit more practice today with EKGs. So I found this website that I thought was kind of fun, and I linked it on our, I think I put it on our resources page. If I didn't put it on the resource page yet, I will at the end of today. But this, you can click on these different rhythms and it will show you what the rhythm looks like, especially in real life. So this is a sinus rhythm. So what are some of the characteristics of the sinus rhythm? It's regular. It's all in sync. Yeah, I see P waves and I see a P wave before every QRS complex. So it looks pretty good. What about, and then what's the heart rate?
72.
Well, let me, oh, good. Oh, and look, I could even pause it if I put over. Ah, that's so great. Okay, let's count the, sorry, I'm so excited. Let's count the QRS complexes. 1, 2, 3, 4, 5, 6, 7, 8. Well, if you said 80, I would give you credit. On here it says 72, but that's probably because it's, it's a more precise, you're using a more precise way of recording. All right, so now if we go look here, this is sinus bradycardia. What are the similarities between sinus bradycardia and normal sinus rhythm that we just saw? It looks almost exactly the same, right? It's just slower. What is the rate difference for sinus? Like, what is the normal rate for sinus bradycardia? It's just less than 60, right? You don't want to get lower than 50 usually. If you get 40s, you're kind of concerned. But yeah, it's regular. There's P waves with every QRS. It all marches out. What about if we go to sinus tachycardia? What are similarities between this and normal sinus rhythm? Yeah, it looks the same, just faster, right? You just sped it up. So do the words make sense to you when I say bradycardia and slow and tachycardia and fast? Okay, those are some of the more common prefixes or suffixes depending on where you're using them, but those will really help you if you remember. Bradycardia is slow, tachycardia is fast. And what's the rate for tachycardia? Over 100, right? If it's over 100, it's going to be tachycardia. All right. Let's count these QRS complexes just for fun. If we count them, we've got 1, 2, 3, 4, 5, 6, 7, 8, 9, 10, 11, 12, 13, 14, 15, 16. We would know their count of this. Maybe there's something different than what I'm seeing. But I would say, what did I say, 16? I would say, what would the rate be? 160, right? I wouldn't say this. What about, let's go over and look at some of our atrial rates. You know what I'm going to do? We're going to go to flutter first because flutter is easier to recognize. Okay, what's similar about this to normal sinus rhythm? Yeah, you can see it's kind of the QRSs are regular, right? They're happening in a regular pattern. And are there P waves? There are P waves. We see them, but there's too many of them, right? There's too many. And what's that characteristic of atrial flutter that we look at for the P waves? Do you remember what it's called?
Oh,
Yes, the sawtooth pattern. See how it almost looks like if you guys ever like cut wood or anything with a saw that you go back and forth, it has that sawtooth pattern with it. If you see that sawtooth pattern and the QRSs are regular, they're kind of marching on down in a regular pattern, that means we have atrial flutter. That sawtooth pattern, I like to think of like butterfly wings, like they're fluttering along. Now, atrial fibrillation, I think that can get a little more tricky for patients. For students or just nurses in general when we're doing EKG interpretation, because the fibrillation, what's happening in our atrium when we have atrial fibrillation? Yeah, good job, Jade. It's just like spazzing, right? And that's kind of what it looks like, right? The atrium is just kind of spazzing out, and so we don't get any kind of regular line or regular pattern because the atrium is essentially having a seizure of some sort. And so when we have AFib, we get this really amorphous, irregular P wave, and we can't even really see P waves. What's different about the QRS complexes when we look here? They're very irregular, right? With a flutter, we had EKG complexes that were happening regularly. But with a fib, they're just like bouncing around. There's no regularity to it. I don't want to. I don't want to. Okay, let's look at our ventricular rhythms, okay? So this is VTach, or ventricular tachycardia. Remember, this is where nothing really is happening from the sinus node or the AV node. It's the ventricles who are kind of controlling the show. And we know that because what's different about the QRS complex? It's really wide. That means that there's that beats or the signals coming from the ventricles from down low. So, you know, and I kind of think with the wide QRS complexes, it almost looks like a V to me. So that's my clue that I use in my brain is like, okay, if I have a wide QRS complex, it kind of looks like a V. I know it's from the ventricles. And what's the rate with this? Really fast. I'm not going to count it again because I'm just disappointed every time because I'm counting a different number, right? But they're saying for here, it's 210, which you'll see with VTach. Is 210 beats per minute sustainable? No. This is somebody who is not doing well. You might have somebody that would have, they call them bursts of VTach, where they have a normal, they might even have a sinus rhythm or some sort of rhythm happening. And then they'll go on to these few second bursts of VTach, and then they go back into normal. And if you have them on a heart monitor, the monitor is going to bing, 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 bing. And you're going to go check with the patients. And usually they'll go, oh yeah, my heart just felt like it fluttered or something. Look, it doesn't feel good when you're in VTach. This is somebody we need to see right away. All right, what about this rhythm? They're not really contracting very much. So remember we talked about atrial fibrillation, how the atrium or the P waves look like they're just kind of having little spasms. This is ventricular fibrillation. So sometimes students are like, wait, is it atrial or is it ventricular fibrillation? How would we know the difference between atrial fibrillation and ventricular fibrillation? Yeah, is there a QRS, right? Because if I would go and just plop some QRSs on this rhythm, it would probably be AFib. But there's no QRS contract. There's no, like the ventricles aren't actually giving a good contraction. So that's where I can say, okay, this is VFib because there aren't any QRS complexes that go across.
What's the difference with supraventricular tachycardia versus?
Yeah, good question. So ventricular tachycardia, nice big wide waveforms, right? And it's wide because the signal is coming from the ventricles. That's what's kind of saying when to beat. With supraventricular tachycardia, does it have it on here? Oh, there we go. Thank you. With supraventricular tachycardia, your QRS is still narrow because it's tachycardic, but we know that the signal is coming from above the ventricles. It's too fast to really see. I can't see P waves here. I don't know what's going on. And so it's kind of where it's like, okay, it's too fast for me to be able to diagnose, but the QRS is small, so I know it's above the ventricles. So I'm not going to test you on supraventricular tachycardia, but that is something you might see, and just know supraventricular just means above the ventricles. If it's above the ventricles, the rhythm is going to be nice and narrow and skinny. If it's below the ventricles, you're going to see a real wide QRS complex. What I want you to be able to recognize is VTach, VFib. Those are like dying people rhythms, right? VTach is somebody who's circling the drain. VFib is usually somebody who's actively like going down the drain. They probably don't have a pulse. And sinus bradycardia. That's one that I want you to also be concerned with, because if somebody's heart rate is going so low, sometimes you might not have the perfusion that you need, right? It might be that they're like a runner. They run, they've got a really effective heart and it's pumping really well, and their heart rate's normally in the 40s, and that's just where they live. Or it could be grandpa's heart starting just to not do so well, and we need to make sure he's all right. And let's see, I want to see if they have, do we have asystole on here? I don't know if I saw it. What does asystole look like? Just flash, right? Right? And it's not necessarily just a flat line. Sometimes we'll see like a little, a little bit, but it's not much. And it's definitely not the same as like the ventricular fibrillation. All right, so I want you guys to actually get up and move a little bit this morning. I love to dance. And so I was thinking we would do a little bit of dancing with our rhythms. So we're going to get into groups. And I'm going to have you guys create for me, us, a little dance that would go along with whatever rhythm I assign you. So for example, I know, I bet you people from home are so sad you're not here for this, right? So here is sinus rhythm. It's just as an example. I'm not going to give anybody sinus rhythm. Look how cute he is. So that's just an example that I found, but based on whatever, I'm just going to throw these at you guys so we can get into our group. Based on whatever group you're in and what rhythm I give you, I'm just going to give you guys a few minutes to decide, hey, what could be like, how could we show what this rhythm is? So, start gathering together.
Look, I get to hear it right now.
Okay, find your. Are you a square? Okay. Anybody feel like they really want to go first and show us what their EKG rhythm dance is? Oh, you got, oh, look, you're so ready. Let's give them a hand for being brave. Both.
We're supposed to be in the same rhythm.
Hold on. That's about.
We're in the same rhythm.
Oh, yeah. Same rhythm. All right. Any guesses of what rhythm they might be?
Tacky.
They're
What?
tacky.
If it's the same rhythm.
If it's a sim rhythm.
And tack.
Anybody guess what it is? Sinus sac? Okay, nice job, you guys.
Yeah, we.
Hold on.
You're not, okay.
I don't know. Are we jumping or are we doing the squat thing? Okay. Okay.
Standing behind you.
Hold on. Five, six, 7, 8.
Okay. It's not supposed to be together.
Yeah.
Oh,
Yeah.
any ideas on what they might be?
Yeah.
It is dark. I was saying that it is.
Yes.
All right, so AFib. So what were our clues that it was AFib? Yeah.
It's purposely supposed to be bad.
Yeah.
It's planned out.
All right, nice job, you
Yeah.
guys. Nice job.
I like it's early. I'm just.
Oh, here, I know what I can do. Look, I'll show you the rhythm with it, right? What do we say, AFib?
Yeah.
Look, that's what you guys were. You guys were AFib.
Super fast, guys.
Is it Brady?
It is super fast? Oh, okay.
Same.
I hear sinus Brady over here. You guys? Yeah, and? Sinus Brady, good job. What were our clues?
Slow.
Yes, slow.
Regular.
And I kind of saw like a little, like maybe the atrium where they were trying to come out there. So sinus bradycardia, nice and slow with P and QRSs. All right, who's brave and wants to go next? When you are so lucky, you're missing out on dancing. Anybody have ideas? Or what are clues that we could pick out? Big and open, yeah. Yeah, VTAC. Oh, good job, you guys. That was creative. I like that. The big and open. So if we look at our VTAC on the screen. Right, big, that's kind of, that's what you, exactly what you guys did. Well done. You guys even color coordinated. Look at that. So
Yeah.
good. Wait, is this part of the dance?
I'm sorry, our fun is so dance. Our dance is funny, but it's.
Okay. Okay. Any clues with the dance? Yeah, it was, are these flutter waves? A flutter?
Yeah.
Oh, give it up for Victor and his backup dancers. Okay, did you guys went? Any, okay, yes, you guys, come on up. You're a last group, right? All right, let's give it up for them. Last group. Okay, what are our clues? Chaotic, yeah. VFib?
Yeah.
Oh, good job, you guys. Oh, I forgot to show so VFib. That was, look, you guys look like it's the same thing. And then what was the group before? Was it flutter? And then a flutter with the backup dancers. On the side. All right, so hopefully this helps you guys kind of think, when you think about these rhythms, kind of put it into your mind about what they are, what they look like. We'll go into a little bit more. I want to do a little bit of quizzing with you guys though. So as your groups, I want us to go through and we're going to do a little bit of questions with rhythms, okay? So we're going to identify these. So for the purpose of this question, and all my test questions, we're just going to pretend that they're all 6-second strips. So do you guys remember the steps we take for a rhythm interpretation? Yeah. What's the first one? We could look at rate. That's a fine one to start with. What is our rate with this one?
If we're doing 6, it would be 3 times 10.
Mm-hmm.
Or you could
So
do
how
that
many
with
QRS complexes are there? 5. If it's a 6-second strip, how much do we multiply it by? By 10, yeah. So 5 times 10 is 50. So that already tells us it's going to be what type of rhythm? Bradycardic rhythm, right? We know it's going to be slow. So then, what else do we look at with the rhythm? Is it regular? Yeah. Does it march out? Does this one march out? Is it regular? It looks to be. Are there P waves? Yeah, there's P waves. Is there a P wave before every QRS? They seem to be kind of equal in the distance. So what do we think this probably is? What's that?
normal sinus rhythm.
Normal sinus rhythm? Brady. Sinus bradycardia. Yeah, so you're right, it is a sinus rhythm, but it is, wait, normal sinus?
Yeah, that's one.
Yeah, it says it on the bottom of the strip right there.
That should not be normal sinus rhythm, and this is 6-second strip. I'm just shocked. Okay, if this was a 6-second strip, we would call it sinus bradycardia. Just want to make sure we know there's a difference. Normal sinus rhythm is where the rate is between 60 and 100. There's nothing abnormal about it. Oh my gosh. Okay, I don't like that at all. Okay, this one does not have the answer on it. So let's follow what's the first thing we're going to look at? If it's regular or not. Is this regular? No, it's irregular. Really quick, let's look at the QRS complexes. I think that's helpful. Are they nice and narrow or are they wide? They're narrow. So where is that rhythm? Where is this impulse coming from? It's somewhere up, somewhere the atrium on the top. So it's not regular. How fast are we? Pretty fast, right? We can kind of eyeball that and say, oh, that's above 100. Do we have P waves? Right, not discernible. They're tough. What do we think this would be? AFib. Anybody say a flutter? No? Okay, good. Because it's AFib. Good job, you guys. All right. What about this rhythm? What do we look about? Like, what do we first look? Is it regular? Yeah, it's regular. What's the rate? It's fast, right? It's going to be a tachyrhythm. QRS, are we nice and tidy or wide? So that kind of tells us what we're at, right? What are we at? Ventricular tachycardia. Good, guys. You're doing so good. I'm so proud of you. Okay, this one's really hard. Anybody want to guess? Asystole, right? And like I said, typically asystole, it's not going to be just this flat line. There will be a little bit of variation on there. All right, this one. So do we have a regular rhythm? It's pretty regular. What about the rate? I'm counting about 9 QRS complexes. So that would be what rate per minute? About 90. What about the QRS complex? Is it narrow or is it wide? Looks nice and narrow, so it's probably coming from the atria somewhere. What about the P waves? I heard a key word here, sawtooth. What do we have? Atrial flutter. The sawtooth waves, they're the flutter waves. And remember, atrial fibrillation, you're going to have a very irregular rhythm. Atrial flutter, because the atrium, it's kind of like like what you guys did in your dance. They're kind of fluttering, and then it like beats. And then it will flutter, and then beat. So it's more regular, where the fibrillation, that's when the atrium are just kind of spazzing out and the ventricles beat randomly. So fibrillation, you're going to have the sawtooth pattern and a regular rhythm. All right. Well, do we have a regular rhythm? Doesn't look like it. Fast, slow, probably. What about our QRS complexes? Do we even have much? What do you think this is? Ventricular fibrillation. Yeah. Nice job. Okay, that was it. That was just our little like EKG review. We didn't get a really close in, on EKG last week. And I wanted to make sure we could just kind of make sure we're on the same page. As we go and talk a little bit more about patients, I want us to make sure we understand about how we would treat them as well. Like if we have a patient who is sinus bradycardic, right? It's nice and narrow QRS, but it's really slow. You know, what might we have to do for that patient? Usually not calm them down. They're a little too calm.
Make them excited. Give them some medication.
We want to stimulate the sympathetic nervous system. Elizabeth, what did you say?
I was thinking of like raising the edge of the bed, make them more comfortable.
Maybe, but I want to remember too, if it's going too slow, that means that the electrical current, the one I drew out, that's not happening nearly fast enough. And that's when we talked about how sometimes they have to do that pacemaking, right? Different than defibrillation where you shock, but where sometimes if it's too slow, they might have to apply pacing pads and give the heart that extra current to make it go faster. What about if you have a patient who you see on the rhythm and it looks like the VFib, it looks like, or VTAC, it just looks crazy.
That's when you would probably want to check on
We want to check on the patient, right? Because let me bring it up. I don't think we had time to talk about it last week, but I've had patients who it looks like this on the monitor. And the monitor is ding, 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 ding. And I'm going, oh no. And I run to my patient's room and they're brushing their teeth. Because think about the monitors that we have on our chest. If we're brushing our teeth and we're kind of shaking things, it makes the leads read differently. If you have somebody like, right, like think about like our chest, everything, if we're moving, those leads aren't getting a nice, great picture. That's why when we do 12 lead EKGs, we tell them, they're laying on the bed, we say lay really still, don't talk, because we don't want to get a nice clear picture. If somebody's wearing a heart monitor, they're talking, they might be itching their chest, and it looks like that because they're moving that little monitor. We always want to make sure if we have something like this, the first thing we're going to do is go look at our patient, okay? Yeah, believe it or not, there have been people who see this on the monitor and they call a code or a rapid response And the team runs down to the room and the patient's like, what? I was just getting ready. Like they were like they were just getting their clothes or doing something. So want to make sure we always go and just look at our patients first. Okay, that wraps up EKG stuff. So let's move into our menti occlusive. There is such a dense, I don't know, I don't love the content from today. I have to say, like most of the other systems or the other parts of cardiac resonate with me more. So I just it didn't spark as much joy with me today, but I think we're still gonna have a good time. We're gonna talk about occlusive disorders of the heart and then valvular infective, but I don't want to really stay on it. Like if we don't get through all the mentees, I'm not gonna worry about it. Review the information, but I'm not gonna stress about making sure we get through every piece. Does that make sense? Yeah, okay, so let's start with our first mentee. Let me pull up the QR. Yeah, if you want to go back to your other seats, you can. We'll do some other teamwork stuff later. What did I say? Occlusive. Once you've joined, if you could give me a little thumbs up or like, I think we're gonna put the extra reactions in. We don't have the cat anymore. I'll try to remember that for next week. Some of the disease processes that we're gonna focus on, you can see here on our board. When we do our, name that patient or define the disease game later, these are gonna be some of the ones we're gonna talk about. These are kind of the main focuses of the disease processes today. So that's a clue. You're gonna want to know what these are and what to do with them. All right, so are we ready? We're not gonna get through all of this before we go on break. We'll probably take a short break around 9 o'clock, just so you guys know. So we talked about high blood pressure and high heart failure. And I just want to reiterate that cardiovascular disease, any issue with the heart, is leading cause of disability and death in the US. So it really does impact us and how we try to take care of our patients, right? Because it affects so many patients. Who's done clinicals so far? Yeah, did you guys encounter any patients that didn't have either high blood pressure, hyperlipidemia, high cholesterol, heart failure, anything that didn't have a heart issue? Yours did? Kind of?
Mine all have like hypertension.
Yeah.
You're gonna see it be a
Like every
really
single one.
common thread, especially as people get older, because some of the things we're gonna talk about is that our heart and our blood vessels over time start to not function as well. And so there's a natural deterioration that we see. So one of the things that we want to make sure is that education is so important to treat cardiovascular disease. So arterial sclerosis, that's where you have, this is our artery normally, and where you have the arterial walls and lose their elasticity. They're not able to stretch and move. Like remember, when we get warm, what happens to our blood vessels? They dilate. As we get cold, they constrict, right? Those same mechanisms come into play when we're trying to control our blood pressure. Sometimes if our blood pressure is higher, our body tries to compensate and dilates our blood vessels to relieve some of that pressure. But over time, we're not able to stretch and move those blood vessels enough or as much. And so our pressure will go up. You also can have plaques that build up in the artery themselves. Atherosclerosis, that's where you have the plaques that build up. It's really interesting. We used to almost always see this in older adults, actually starting to see children with high cholesterol and some hyperlipidemia, which is crazy to me. But this can start in childhood and we start seeing signs and symptoms as people get older. So as those clots form, those plaques, or I should call them plaques, they build up, the blood can't get through like it needs to. And as the blood blood's backing up a little bit, or sometimes things like platelets and other stuff, components in our blood can stick to that and form a clot. If the, okay. Sorry, it's telling me we're not hearing so well. If that clot breaks loose, or even that plaque could break loose, it forms like a little plug in our arteries. Especially we think about going to our cardiac or our heart arteries. So non-modifiable risk factors. This is really similar to hypertension, right? How old you are, your gender. Which gender has a higher risk of atherosclerosis and arterial sclerosis? Men, yep. Ethnicity. What ethnicities have a higher risk of this? African American, Hispanic, what else? Those are the two main for the US. And you can also have genetic predispositions. If you have a family history of high cholesterol or hyperlipidemia, you might just have a genetic component that puts you more at risk for it. You can't modify that. But what can we modify? So if Mr. Argwal, we want to see, does he understand our teaching if he lists which of these as modifiable risk factors? So select all that apply. Which of these are modifiable risk factors?
It only lets us choose one.
Good grief, I thought I fixed that. Sorry, guys. We'll choose whichever one strikes your fancy. That's a great question. Actually, would you say that a little louder?
Can hypertension be modifiable?
Yeah, what do you guys think? Is
Yes.
hypertension modifiable? Yeah, absolutely. That's why we were talking all in the previous weeks about we do so much with like lifestyle education with them. So correct answer is yes. Hypertension, we want to modify that and bring it down. We can't ever get rid of somebody's hypertension, meaning they always will have that disease, but we can modify it and keep it controlled. Same thing with obesity, smoking, and sedentary lifestyle. We can do something about those. Those are modifiable. One thing on here, did we say smoking on the other page? We did? Okay, yeah, smoking. Smoking is so bad for your heart and your blood vessels. Really can contribute to those walls having, the blood vessel walls having damage. So if we have somebody with atherosclerosis, we're going to get some blood tests. Their cholesterol level is going to be high. Their LDL, or low density lipoprotein, that's going to be pretty high as well. Their high density lipoprotein, that's a good one. We want them to have HDL. That's kind of a protective mechanism of the heart. So when you have somebody, you're like, oh man, HDL is low, that's great. Actually, it's not. We want it to be higher. And then their LP cholesterol, if it's elevated, that's another risk factor. So which is the one that we want to be high? HDL. The high density should be high. We want it to be high. Everything else, we want to keep it lower. So we also would probably check their triglycerides, and then their CRP, or C-reactive protein. That's a marker that tells us about inflammation and if their coronary arteries are inflamed. We might look at their CRP. So what do we do for them, right? A lot of this stuff similar to the blood pressure, where we're going to modify what they're eating, right? We're going to try to have them eat a heart healthy diet, but also really look at lowering those fatty sources in their diet. We also want to teach them about not smoking, exercising. They might even take some medications that are going to help those lipids and cholesterol lower a bit. So coronary artery disease. That's kind of like an offshoot. When I say atherosclerosis, coronary artery disease kind of goes hand in hand, because coronary artery disease, when we have the blood vessels, the arteries that feed the heart, that's when they're getting plaques that build up inside the heart, and they're not getting blood to the heart muscle itself. I wrote the abbreviations on here. So coronary artery disease, CAD, you're gonna see it be abbreviated. When you guys start going to clinicals, you're gonna see, I have students come to me all the time and go, what does this mean? What does this mean? What does this mean, right? And you guys know HTN is hypertension, right? But there's so many other diseases we haven't talked about that they use abbreviations for. So just ask. So with coronary artery disease, we have blood flow that kind of slows down. It can't get to the heart muscle like it should. Sometimes they're going to have angina. They might have a myocardial infarction, and it might end up with sudden death. And we're going to go into a little bit with each of those. So prevention, we already talked about what we're going to do for prevention for risk factors. One thing I didn't talk about is normal blood sugars. If you have somebody who's a diabetic, having increased blood sugar can actually increase their risk of having coronary artery dysfunction. Then, usually we give people low dose aspirin. Why do we give them aspirin? Yeah, it's a blood thinner. If we know that those coronary arteries are already getting kind of blocked, we want to make sure that the blood is less likely to form those little clots and block up the rest of the arteries. Bum, bum, bum. Okay, so angina pectoris, right? What is pectoris? Yeah, if you've gone to like the gym, they have like the pec machines, right? So that's when somebody has chest pain. When somebody's having chest pain, specifically we're talking about the heart, it's meaning there's muscle damage that's happening to the heart. We've talked about referred pain a little bit, like with our kidneys. Where do we feel our kidneys hurting us, right? It's usually in the flank area. That's kind of where it refers to. When we have pain from the heart, from that muscle, it's usually referred out to the chest and some other areas. So why do the chest pain, it's a symptom of ischemia. Do you guys remember what ischemia means? Yeah, tissue death. It's tissue death around that area of the heart. Blah, 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 blah. We talked about that. Okay. Which of the following symptoms would the patient with stable angina be able to report to the nurse during data collection? So if you have a patient, you're doing your assessment, which of these are symptoms of stable angina? Can you choose more than one? Let's see what we have. Okay, so the chest pain required oxygen for relief. No, we're going to talk a little bit about stable versus unstable angina. Meaning, if somebody's having chest pain, stable means we're okay. We're going to watch them. We're going to see what happens. Unstable means you need to go to the emergency room, hopefully somewhere that has a cath lab, because we know that you are in, like, your heart is in grave danger. So if the chest pain required oxygen, that puts them in the unstable category. If the chest pain occurred with moderate exertion, that's stable. That means they were doing some activity, maybe they were exercising, and they started having pain. And so that would be stable. If it was light exertion, they just started walking across the room and that caused chest pain, that would be unstable. Now we have the chest pain was not relieved with rest. If it's stable, it should stop. Like if you're working out and you have chest pain and then you stop working out, then it goes away because your heart's able to get all the blood that it needs, all the nutrients or the oxygen. The chest pain occurred in a predictable pattern. Again, going back to that walking or exercising thing. Somebody might say, I know that every time I hit this hill I walk around my house and I hit this one hill, it always causes me to hurt a little bit. It's predictable for them because they know when they exert to a certain amount, it starts causing some pain. The chest pain lasted just for a few minutes, right? It shouldn't be continuous. It should be short term. If it was continuous, it didn't stop, it lasted for a long time, that would be unstable. And nitroglycerin relieved the chest pain. These patients who have coronary artery disease, a lot of times, you guys seen the little tiny bottles of nitroglycerin? Yeah, no, they're so tiny. Oh, I wonder if they have any back here. most med carts and Pyxis machines will have these little bottles of nitro, and they're just so darling. When I first saw them, I was just like in love with them. Yeah, they don't have any here. Elizabeth, you okay? Something in your eye? I'm sorry, girl. So the nitroglycerin bottles are little tiny bottles. Do you know why we keep them so tiny? So they can carry them with them, right? We usually say put it in your pocket. Because your nitroglycerin does you no good if you're out exercising and your nitroglycerin's back at home in your cabinet, right? The pills are really, really tiny. They're so tiny. And it comes in a brown bottle. You guys remember from pharmacology, why is the bottle brown?
So you don't get it like mixed up or?
It protects it from
Because of
light,
light.
right? The light will degrade the medication itself. Now, do you guys know how we give nitroglycerin? Sublingual and there are patches too. Sometimes people can have a patch, but typically when we're giving it for coronary artery disease for prevention if they start having chest pain, it's sublingual. So we give it to them. We say, if you start having chest pain, you should take this. And then
Right, isn't it if it doesn't go away, you give it again?
exactly. The rule of thumb for nitroglycerin under the tongue, right? We don't want them to swallow it because under our tongues, remember anatomy and physiology, there's so much blood flow going through our mouth. And if we go under the tongue, it will dissolve and get into our bloodstream much faster than if we swallow it and it goes through our digestive tract. We give it 5 minutes, and if the patient is still having pain, we give another dose. You wait another 5 minutes. If that's still having chest pain, we give a third dose. And then by that time, if it's still happening, you call 911. This is for somebody who has stable coronary artery disease. That the doctor has said, yes, if you have chest pain, take this. And the doctor's office should be, we should be giving good instructions to them to say, make sure to call, somebody, I just want to be clear, if somebody's not been diagnosed with coronary artery disease and they're just out in the wild and start having chest pain, we don't want to go like, hey, can I borrow your nitroglycerin so I can give grandpa this, right? Like, we don't know him, so we're not going to be, we're just going to be calling 911. This is just for patients who've been diagnosed with coronary artery disease. Okay, nitro's fun. Actually, just because we're talking about nitro, what does nitroglycerin do? It vasodilates. That's its mechanism of action. So all of those blood vessels open up, especially when we're talking about the heart and those coronary arteries are getting blocked. We want them to open up so that blood can get through to all the muscle of the heart. But it can't selectively dilate just the heart. It dilates, it dilates the rest of the body. So if we're dilating our blood vessels for the rest of the body, what does that do to our blood pressure? It drops it, right? Big side effects from nitroglycerin are going to be low blood pressure and headache because we have dilated those arteries in our brain as well. And people feel it. That's one of the biggest things when I've had people on a nitro drip or given them nitro, they're like, oh, my head's pounding now. And I'm like, yeah, well, your heart's getting perfused. So you two get to choose one or the other. Okay, so we talked about types of angina, stable versus unstable. So I'm going to kind of go through this. Which of these are signs and symptoms of angina or chest pain that are typically seen in women? Select all that apply. It still only lets you choose one, right? Okay, I figured. Okay, so women are unique, aren't we? We do have the typical signs and symptoms of chest pain, being like we might see women that have the jaw radiates. Actually, it's usually the left side that will radiate up the jaw, sometimes down the arm, or sometimes back down the scapula area, and just general chest pain. Women do not usually have symptoms. In fact, they don't describe it as being more severe. Women, most of the time, will downplay their symptoms. In fact, they'll usually say, I'm just tired. I've just been tired for a while. I can't catch my breath. Women are really hard to diagnose because they don't have the same symptoms or they don't present the same way. And because of this, they don't get treated the same usually. One thing that we're trying to make sure as healthcare providers is that when we have women who come in with some of these atypical symptoms where they say, something doesn't feel right. I've just been tired. I keep getting short of breath, but I think I'm fine. We know to go, let's look at your heart because a lot of women present this way for a heart attack. Yeah. And so, we do this education with you guys. They do this education with doctors, nurse practitioners, because what we found is that a lot of women were getting sent back home from the ER because they were like, oh, you seem to be fine, but not really running tests. And they would have a massive MI. So I want to make sure we're able to know that men and women are, even though men are higher risk for having a heart attack, for having something go on with their heart, women don't, women have different symptoms. So we want to make sure we're assessing them correctly. What about this? What would the nurse include the patient's teaching plan for pre-hospital care for an MI? This is kind of confusing. So let's go through really quick with our test question. I know I talked to a lot of you guys about how to read test questions. So the first thing, we're just going to read it. Always when you have a test question, read it. So what would the nurse include in a patient's teaching plan for pre-hospital care for an MI? I don't love how this question is worded, but it's from F.A. Davis. And so I want to give you publisher questions because they're kind of harder. So let's pick out the clues. What are the flagged words or the clues that we can pick out from this question? Patient teaching, pre-hospital care, an MI, right? What's an MI? Yeah, myocardial infarction. I'll talk about that, but that's where you have heart. The heart muscle is actually a piece of it or been severely damaged. So, what is this question asking us? Because there's a lot of words in here. Is there a way to sum it up? That's perfect. We say it a little bit louder so people could hear. Yeah, what should the patient do before they come in? So, I guess I should give you guys a chance to answer. Now looking through, what do we think they should do? So, correct answers, we want them to make sure they know, do not drive yourself to the hospital, right? There's a few reasons for that. One, if you're having a heart attack and you're driving and all of a sudden something happens and you pass out or you can't drive anymore, you're probably not going to get to the hospital and you might injure some other people. You might get in a wreck. The other thing is, when you call 911, sometimes people think, oh, I could just drive them to the hospital. It'll take, by the time they get here, I could be halfway to the hospital. But what we forget is that our EMTs and our medics that come in the ambulance start treating people. If you're having a myocardial infarction, they're going to be able to hook you up and look at your heart monitor to see what rhythm you're in. They're probably going to give you some aspirin. They're going to start an IV. They're going to draw some labs. They're going to call ahead, and if they know they're like, oh, they're having a heart attack, they're going to make sure to take you to a facility that has a cath lab, and they're going to call ahead and have it ready for you. None of that happens if somebody drives themselves to the hospital or if they have somebody else drive them. They're like, I don't want to pay for an ambulance. There's so much with the time. Like, I know we talk a lot about time with strokes in our brain, like time loss is brain loss, but I want us to also think about time as muscle as well. The longer we wait for time to treat a heart attack, the more muscle that's getting damaged. Okay, moving back, call 911 after 5 minutes of unrelieved chest pain? Absolutely, right? If it's not getting relieved, typically at home, I know I said there's every 3 minutes or every 5 minutes. Yeah, I guess Davis wants us to do one. In the hospital, if you're the nurse, you'll probably give it 3 times. You're still gonna be notifying your provider as well. Swallow 2 coated baby aspirins. Why is that an incorrect answer? There's a couple of reasons why. Right, it kind of, so baby aspirin, we don't actually give aspirin to children, but they call them baby aspirin.
Oh,
They're the 81 milligram aspirin. So what does coated mean? Yeah, enteric coated. So what does that do when you take the pill? It delays the release of the medicine. Do we want to delay the release of aspirin if somebody's having a heart attack? No, we don't. In fact, what you do is you say, here's your aspirin, chew it up. And they're like, this is disgusting. And you're like, yep, you want to live. Like you just, I know it sounds horrible, but you don't want, you want them to chew it up and break that down as much as possible so it gets in their system. If they let it go through digestive tract, it's going to take even longer. And typically we do 325 of aspirin, 325 milligrams. 281 milligrams is 162 milligrams of aspirin. So it's not enough for the typical dose we would give. Yeah. Yeah. Why would we not want to ride with a family member? And remember all that work that the EMTs can do? They're giving you aspirin. They're doing an EKG. They're calling ahead. They're making sure you go to a cath lab hospital. Sometimes patients, I've seen them around here, they have somebody take them to St. Clair and Lakewood because they're having a heart attack. They shouldn't go to St. Clair because St. Clair doesn't have a cath lab. Where they should go to St. Joe, TG, somewhere else that has a cath lab. Families don't know those things, right? We don't expect them to know those things, but our ambulances and our EMT providers, they do know those things. So that's why, because, right, if you take them to St. Clair, right, you're like, I live right by St. Clair, I can just take them there. But now you've wasted so much time by taking them to St. Clair. And then they have to triage them, figure out what's happening, get them ready, and then transfer them to St. Joe's or wherever. It's just, there's so much time that's involved with it. I know people get really urgent. They're like, no, 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 we can just take them now. And it's like, you should just call 911. I know it's so hard for people. Okay. Did I talk about this? Yeah. So silent ischemia. I just want to make sure you guys know that somebody can be having a chest pain, but have no signs and symptoms, right? There can be damage happening to their heart and they feel absolutely fine. A lot of times it occurs in older patients and women, right? I think women are just tough. I know men are tough too, but I think women are just built a little different with some of these things where they're just like, I'm having a heart attack. I guess it's another Tuesday. And they just keep living life. And so we want to make sure we know that this is a thing. Oftentimes, this silent ischemia, where they're not these obvious signs and symptoms, it happens with patients who have hypertension and diabetes. Okay, those are correlated. Sudden cardiac death. That's usually where you have a lethal ventricular rhythm or a systole that happens from a occlusion of coronary artery. So what that means is in the heart, you have a blood clot and it gets stuck in one of your coronary arteries. And so the blood isn't getting perfused to that heart muscle. And so your heart is like, huh, I don't have the blood and oxygen I need. And so it goes into a lethal cardiac rhythm. Okay, we've learned about these. What are the lethal cardiac rhythms, especially those lethal ventricular rhythms? VTAC and VFib, right? And you could probably include asystole, but that's not lethal, that's already dead, right? So lethal cardiac rhythms, VFib, VTAC, and then asystole is dead. So if somebody has sudden cardiac death, there are times that we can treat that, meaning if you're, especially if you're in the hospital and you fall over from a sudden massive MI, if we can get you treated and get you right into the cath lab, there is a chance, you know, when they're probably doing CPR, they're doing all they can to help perfuse that heart. There's a chance that they can open that artery back up and that patient could live. But it needs prompt treatment very fast, and it still has pretty low outcomes as far as patients who live after this. Oh gosh, I'm so sorry, you guys. We're going to talk about balloon angioplasty in a minute. So when I say cath lab, that means, thank you so much for asking. So one thing I want to level set is that this is a place of learning, and it's a place to know, to not know, right? It's okay if you don't know words I say or phrases or terminology. And a lot of people are like, oh, I don't know, I'm sure I'm the only one who doesn't know. But I'm guessing there's a lot of people who don't know what cath lab is. And so I'm so thankful that you asked. So please, this is a safe place to say a medication name wrong or mispronounce it or ask questions. Cath lab is has Chuchi talked to you guys how she works in like a special procedure lab? Okay, so it's a place where you go, and cath lab specifically, when we're talking about heart, is they have specialized providers, doctors who are specially trained to take the patient in, and they usually go in through the groin. Sometimes you can even do through the artery in your arm. And they snake a little catheter, so that's what we call it, the cath lab. And they snake a little catheter in, and they snake it, if it's from the arm all the way to wherever the heart is cutting its blockage, or the femur or femoral area all the way up to the heart. And they find that area that's blocked, and they either try to break up the clot, or if it's like a real narrowed area, they might try to open up that area as well. So that's, and not all facilities have it because it's a very specialized type of place. It's like not all hospitals in rural areas have operating rooms, right? Because it's a very specialized type of area. Cath lab is very similar, that not all hospitals have a cath lab. So myocardial infarction, that's where we have death of the heart muscle. Two types. You're going to hear these words, non-STEMI and STEMI. What I want you to remember is that STEMI is bad. STEMI means there's a complete blockage, and you're going to see more symptoms. This kind of gives you a little picture of what it could look like when you have a blood clot that happens like right down in here. So right around the area of the clot, you're going to have this area, the black was where it's necrosed, dead. And then you have kind of an area of injury and ischemia where it lost some of the blood flow. I just realized it's after 9 o'clock. I keep looking at this clock. How about we pause and take a break for 15 minutes? So come back at 9:25? Yeah, okay. Okay, so we left off talking about ischemia. Let's continue on our journey here. There we go. So symptoms. We talked about how women will present differently than men, but typical symptoms, people say a crushing pain, meaning like if somebody, sometimes they'll say, I feel like an elephant is sitting on my chest, like this pressure. That's what crushing mean. Vice-like, a vice is a tool that people use in like woodworking and stuff, and it like clamps down and gets tighter and tighter. That's what vice like something is grabbing you and squeezing really hard. You might be diaphoretic, or you might be sweating. You might have difficulty breathing, maybe nauseous, maybe restless. A lot of times people have denial, right? They're like, I'm fine. It's just acid reflux, you know. But again, that time is muscle is key. We want them to call 911. Don't drive yourself, because reperfusion time is critical. When we say reperfusion, that's when we're talking about like a cath lab or something where we can go in the special unit and they can open up those cardiac arteries to perfuse that area of the muscle that lost blood flow. We talked about men and women. Coronary artery disease and myocardial infarction is the leading cause of death in women. So it really is key that we do our assessments appropriately, and we're really assessing women for these vague signs. Black women are even higher at risk of this. They do have a higher mortality rate than men, meaning they're more likely to die of this than men are if they have the same condition. They wait longer than men and they have more complications. They also have these prodromal symptoms about a month before the MI. A lot of women will just start to feel fatigued, tired, less energy about a month before the MI occurs. Probably there's some blockage that's starting to build up. And so it's these like faint symptoms. Then they have their MI and often the tiredness, fatigue, whatever their symptoms are, get much worse. But they think, well, of course I'm just tired. I've been watching my grandkids all day, or I've been trying to cook for Thanksgiving for the last 3 days, or whatever it is. They explain their symptoms away oftentimes. We talked about atypical signs. Okay, so when we're diagnosing an EKG, so let's say you're working in an urgent care facility, or you're working in an emergency room, what do we do for these patients? They come in with chest pain, or maybe women with atypical symptoms. We're gonna work them up for a heart attack, for an MI. We're gonna get a serial EKG. When they say serial, sometimes they say serial enzymes, cardiac enzymes. What does that mean?
Like the full workup pretty much, or?
No. It's about the timing. So once you start having a heart attack, right? Like if you have an MI and you have like that picture that showed like where the blood vessel got occluded and how the area around it's like getting damaged. Your question?
You can slide. No, one more. One more. Okay, the one that said like people are higher risk.
Yeah.
Yeah.
Yes.
And was that study done just in America or all over the world?
We're typically looking at America, like the United States. So the rest of the world, you're right. Like if you're in a country that's primarily like you're Black and everybody in the country, you probably won't have that be a difference. It maybe is the region that you're at or something else. Every country is going to have people, ethnicities, or groups that are more at risk that tend to get less treatment or treated differently. And so we want to be aware of that so we know our system biases that we have so we can overcome them. So yeah, we're talking about people who are treated differently or treated like they're not, or they're more at risk. We're talking primarily in the United States. Yeah, but good question. So moving on, where are we at? Serial? Yeah, so serial means time-based. So what you do when the first thing the person gets there, you do an EKG and you do blood work. We're typically gonna do you say highly sensitive cardiac troponin. I just want to refer to it as troponin, okay? I want you to know troponin. Just like creatinine tells us function of the kidney, troponin tells us if there's heart damage. Troponin is what's released when the heart is being damaged itself. So normally you shouldn't see troponin in your blood. If you do, that means there's damage that's happening. You get it right, you get the blood work and the EKG right away. And then typically you'll wait 3 hours. And in 3 hours, you do another EKG and you draw more blood work. Then you do that again at 6 hours and usually 12. And the reason why is when you first start having damage is when you first start having symptoms. But as that area of the muscle continues to not have blood flow, that area of damage is going to grow. And so our EKG might change, and those enzymes, those labs are going to be increasing as well. What we've seen is people who come in with with chest pain, having an MI, they'll have maybe a little bit of an elevated troponin. But once we get those serial ones, like later by the 6 hours, the 12 hours, their troponin is through the roof. And then we start to see some changes on their EKG. So here, remember we talked about kind of the tombstone, well, actually, we'll talk about tombstone T-waves, but they do have some ST changes. So meaning the QRS, where it moves to the T. So sometimes with a STEMI. Remember, STEMI is bad. STEMI is all of it is occluded. You might see where instead of coming down and having your T wave, it's just all elevated. That tells us there's a pretty significant area of damage to the heart. You might see it depressed. The T wave is going down instead of going up. That also would indicate damage. Okay. Pre-hospital care, right? Again, time is muscle. Chew, right? Chew one uncoated aspirin. It's so gross. People don't like it, but it will save lives. If you get the blood, you start to thin it so that we can get that blood perfusing through. So our goal is to restore the cardiac perfusion within 90 minutes of when that heart started to have damage. So if you think about kind of our conversation earlier with patients wanting to drive themselves or have somebody else drive, if we can activate our emergency system and get that time or get the ball rolling, get the patient on the right track to get to a cath lab, so much better if they start with an ambulance than if they drive themselves or have a friend drive them. So they might have an invasive procedure like a percutaneous coronary intervention. So this is a picture of what it might look like. So if somebody has plaque that's built up on these walls here, what they'll do is in that cath lab is they take that little catheter and they snake it through that area where it's really thin. See, one can't get through very well on here. And so then they put that little balloon through and then they blow it up. It helps stretch that vessel open a little bit more.
That's like viable, like you don't just like squish out the bone.
The plaque,
Yeah, like the buildup or anything.
it can be, sometimes they'll go through and like scrape off the plaque too. Sometimes if they can't, if it's not plaque, but it's a clot that's formed there, then they can use a thrombolytic, meaning that they give a medication that will break up the clot. Those are very dangerous though, right? Because it causes your blood to essentially destroy the clotting piece that's there. And so you're not going to be able to clot very much, right? You're not, if you have a cut, your blood's going to be just bleeding. So usually if you're given a thrombolytic, even though the action time is very short, they're going to be in the ICU for a day or so we can monitor them, make sure we're watching them on that therapy. But one thing to know, the thrombolytics, very time sensitive, between 1 and 6 hours for when they have symptoms. Meaning if they started to have symptoms at 12 and by 1 o'clock they're in the ER and they're getting everything done, we have to make sure that we could give them that medicine by 6 o'clock. Otherwise it's too long after the symptoms start time. We want to make sure that we're paying attention to the time. They can also put a stent in. So here's another picture where instead of just ballooning it open, sometimes there's a little mesh kind of stent that will open up and keep those arteries opened. Other therapeutic interventions, we want to give them oxygen, right? If their heart is not getting all the oxygen it needs, we're going to bump up and give them extra oxygen. We're going to give them antiplatelets or something to keep their platelets from sticking together. We're also going to give them nitrates like nitroglycerin, right? They might be given morphine in the past. We used to rely on morphine for chest pain, but anymore it's kind of given more cautiously. We want to give them maybe a vasodilator, right? Because we want to open back up those blood vessels. And then depending on what else is going in the heart, we might do beta blockers or an antiarrhythmic, meaning something to help control that rhythm of the heart. One of the things we do with our patients is we want to try to decrease the stress on their heart, right? So long-term, right, we want them to get up and active and exercise. But if they are recovering from a heart attack, if they have had one, we're going to be really careful with them. In fact, they're going to be usually on bed rest for the immediate period, and they might have gentle movement. Like instead of getting up to walk to the toilet, we might have them go to a bedside commode instead, because we don't want to tax their body anymore. One thing too with our patients who have heart issues, we want to make sure that they don't get constipated because we don't want them to strain when having a bowel movement. That can be kind of dangerous for them as far as causing more symptoms. And so we usually have them on a stool softener to make sure they don't have to strain. Bum, bum, bum. We usually like to avoid caffeine as well. We don't want anything that's going to stimulate or irritate the heart anymore. And then we're going to look through all those things about, do you smoke? Let's talk about that. Are you overweight? Let's work on figuring out a plan for you. And then, guys, remember, what are the statins for? For cholesterol, right? It's a cholesterol lowering medication. So we might want to make sure they're on a statin to keep their cholesterol lower. We don't want them, if they've already built up some of these plaques, we don't want them to build up anymore. We might want them on an ACE inhibitor or a beta blocker to help with how the heart's contracting and controlling its rate and rhythm. Sometimes, if a cardiac vessel is totally blocked, we can't go in and balloon it open. We can't go in and put a graft or a stent to keep it open, and you have to do a graft. So as you go out to clinicals, patients have a lot of heart issues. If you see in their chart cabbage, which is so funny, almost once every year, every other year, I hear somebody in our clinical groups be like, why do you think we talk about my patient eating cabbage? I don't understand. And what it is CABG stands for coronary artery bypass graft. In medical term, we just say cabbage because it's close enough. So it's not about cabbage, the vegetable, it's about the graft. So when you look, believe this picture, yeah. So typically the saphenous vein from the leg is harvested, or they go in and have surgery and they remove the saphenous vein from the leg. Then they go to the area of the heart where it's just blocked, and they essentially do a rerouting. They're like, okay, I'm just gonna plug you in here and plug you in here, and that will keep blood flowing. Yeah.
So is that the same thing as like the Widowmaker?
A widowmaker kind of that's talking more about the area of the heart that's damaged, that's more likely to cause you to die. The bypass graft, that's more of if you can't stent it or balloon it open, then we want to go, and this is usually, right, if somebody has an acute MI and they're dying, we don't have time to do this. This is somebody with chronic coronary disease who are like, okay, maybe we started to stent it, we tried to balloon it, it's not working, we need to go ahead and do a graft. So you're assessing your patients, what would be a clue to know that they had this? Yeah, you're gonna see patients that have these long, kind of straight scars on their inner upper thigh. That's where your saphenous vein is. So your assessment skills are so key, you guys. You're gonna talk to your patients and they're gonna be like, no, I don't have any issues. I don't have any problems. And then you'd be like, really, what's this scar from? Oh, well, my heart was kind of clogged. So they took this vein, but now it's working. You're like, oh, okay, so that's pretty significant. But your assessment, like, don't sleep on all your assessment skills, because they tell you so much about your patients and what they've gone through.
The blood still flow through the other artery, unless it's like fully blocked up.
It's usually mostly blocked.
Okay.
Mm-hmm. Cardiac rehab. So after somebody's had a heart attack or an MI, we want to get them back to full functioning. So usually in the hospital, usually starts with education, right? What kind of things do we educate our patients about with heart health? Yeah, their diet. What kind of things we want them to eat? Exercise, lifestyle changes, medication. We want to start all of this in the hospital. And then a lot of times we have people do like their cardiac rehab places where kind of like after surgery, some people have to go get physical therapy. They might go to cardiac rehab where it teaches them, hey, this is how you start to exercise safely. This is how we start to do things so you can get healthy again, but in a way that protects your heart. Okay, I remember what CUS is for, finally. C is concerned. U is uncomfortable, thank you. And then S is safety. I have a safety issue. So we're going to think about CUS for a minute. So we're caring for Miss Cade, who's 55. She's reporting chest pain rating 5 out of 10 that was treated with nitroglycerin and then reported at an 8 out of 10 5 minutes later. Her EKG shows sinus tachycardia, clear lung sounds, apical pulse is 105, respiration's 28, pressure's 126/80. She's anxious and wants you to stay with her. So you're preparing to communicate with the healthcare provider, okay? You are the nurse, right? So think about what we want to include when we're talking to the provider, and then turn to somebody next to you and talk about how you would use cuss. So using one of those words, I am concerned, I am uncomfortable, I have a safety issue. Yeah, oh yes, thank you. All right, so let's bring it back together. Let's see what Davis said for what they would recommend. So for C, you could say, you would introduce yourself and you like let them know who the patient is and say, I'm concerned about her unrelieved chest pain, or I'm uncomfortable with her condition and distress, or I believe her safety is at risk and she requires additional intervention. There's going to be times, you guys, when you are the nurse, you graduated, you passed your NCLEX, and there's going to be something in you that goes, this isn't right. And you might not know what's happening. You might not know what that thing that's wrong is happening, but you're uncomfortable. You feel nervous. It's okay. Don't be nervous alone. Go talk to your peers, talk to your charge nurse who's ever there, and reach out to the provider. Sometimes though, when you're a newer nurse and you say, something's wrong, they're like, well, what is wrong? And you're like, I can't put my finger on it, something's wrong. This is a good tool to use, right? Like, I am concerned about her unrelieved chest pain, right? That's pretty straightforward with what she's saying, but it's giving you guys language to use that helps you to be able to better verbalize what that concern is. Because every nurse out there is going to say, you're going to have intuition. There's going to be time, like over time, you're going to be able to learn this is not right. You're not going to be able to necessarily pinpoint exactly what it is, but you'll have that. I don't want you guys to discredit it, but I want you to be able to communicate part of that to your provider who is taking care of that patient. Because I don't want them to discredit you because we're not able to articulate it or speak about it. Okay, so moving to a different topic, peripheral vascular disease. So it could be arterial or venous. Peripheral, what does that mean? It's talking about peripheral actually just mean not necessarily veins, but I love that you answered. Good job.
So wrong.
In your extremities, your periphery, it's farther away from this core. So typically when we say peripheral, we're talking about hands, feet, maybe bottom of the legs. So when we talk peripheral edema, right? That's usually edema, that's usually in the legs, could be in the hands. It's just somewhere away from the center. So arterial thromboembolism or embolism. So let's break this word down a little bit. Throm, what does throm mean? Usually means like clot, not like a thrombus, it's a clot. And embolism is where it's blocked off something. So when we're looking at arterial side, like arterial thromboembolisms, because the arteries send the blood out somewhere, that's kind of the highways. If you get an arterial area that's clogged, you're going to have pretty sudden symptoms. Excuse me. Like it's common in upper and lower extremities, but that clot usually will adhere to the vessel wall and stop the flow. I don't really love any of this. We're just gonna skip through it. Boop, 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 boop. Okay, when we talk about an arterial occlusion, which is similar to venous occlusion a bit, what are 6 Ps? We read about them in the text, and I think the homework even had the 6 Ps in it. So you can enter them, I think it's just like at random. All right, for time's sake, I'm gonna move on. Pain. Pallor, what is pallor?
The color,
Yeah, the color isn't the same as the rest of the color around it. Pulselessness, no pulse. Paresthesia, what does that mean? Yeah, something, it's not normal feeling, right? Either you can't feel it all, it's tingling, it's burning. What, paralysis? Yeah, it's not, you can't move that area, right? What about poikilothermia?
you're freezing.
Yeah, whatever area that's damaged, it's gonna be the same temperature as the room. It's not that it's really cold, it's just, when we feel people's skin, it should be fairly warm. When we feel these people at the damaged area, it just feels the same temperature as the room around them. So what are we gonna do if they start having a clot somewhere? Probably gonna have them on anticoagulants, right? We don't want them to form more clots. It's not that it's going to, the anticoagulant is not going to break up the clot. It's going to make sure they don't form more clots. Now, the thrombolytics, just like when we talked about in MI, giving thrombolytics, that is to break up the clot. And usually it's kind of some time frame to it, and safety too. They can easily access that vein or artery that you're trying to get to. They might do a thrombectomy, where they go in, kind of like with the cath lab, where they go in with a catheter, and they try to break up or grab that clot and pull it out. So sometimes this can lead to or be in association with peripheral arterial disease. So if we understand a little bit about what the words are, I think it helps us understand what happens. So peripheral, we know that's in our extremities usually. Arteries or arterial, so the blood's that's flowing out, and disease. So something's happening with those arteries that feed the arms and legs. So essentially, because of that, circulation isn't working very well, that blood supply gets reduced. If the blood supply gets reduced to our periphery, it starts to damage the skin around it. Now, peripheral artery disease is not something that happens sudden. When you have a blood clot, arterial or venous, it's usually pretty sudden onset, right? It's a clot that happens, you have symptoms that start. Peripheral artery disease, it's slow, progressive, happens over time. Usually the lower extremities are where we usually will see it happen at. With it, usually it's caused by atherosclerosis, like we talked about, that damage to the blood vessels. And I don't want to go through sorry, but the symptoms, usually you don't have symptoms till later in the disease, once it's kind of already established. Women oftentimes, again, have no symptoms, shocker, right? But usually it's pain, muscle cramping. When you look at the leg, I want you to think in the periphery where you have peripheral arterial disease, it's usually from the knee down. And because you've lost that blood flow, a lot of times they don't have hair there. They're not getting enough supply of blood there to help them grow hair. A lot of times the skin gets kind of dry. Sometimes you can even have some discoloration as well on there. Their toenails start to become kind of thick. How are their pulses going to be? Usually fairly diminished. The patients that you have, where you're like, I cannot feel their pulses, like I'm just struggling. A lot of them have peripheral arterial disease because there's damage and there's actually not a lot of blood flow getting down there. Intermittent claudication, you might hear that. It just talks about intermittently kind of the veins. Sometimes they spasm or kind of close a little bit. It can happen with some diseases. We'll talk about Raynaud's and Berger's disease in a little bit. But symptoms, oftentimes the skin is cool, right? They're not getting that blood flow. Yeah. Oh, great. Yeah. So what would we ask the patient then? Like, did you shake your leg?
It's on the test. It's like, I remember I was like, this depends on like a lot of things.
Okay.
Would that be an answer?
I haven't graded that yet. Let me look, and after our next break, we'll come back and talk about it. Yeah, thank you for asking. All right. So the color, oftentimes we talk about that they're discolored. They can almost be like a reddish purplish color when they're walking. And then if they raise their legs up, elevate them, they can also become pale colored, because remember, it's that arterial flow is not getting through, so that skin around pales. But I guess we should say, so some of the tests that they do, they might do an ankle brachial index, and that's a type of Doppler or ultrasound exam, and essentially they're checking blood flow, right? If they're like, blood is flowing at this much pressure, you know, at the brachial artery, how much is that flowing like around the ankle? What are the arteries flow getting there? So if there's a huge difference, that lets us know there's probably some damage between those in those veins. Do you guys know what a Doppler ultrasound is? Like, they go through and they follow the veins. Oftentimes, if we're concerned about a blood clot in the veins or the arteries, we'll do a Doppler of the legs to see if there's a clot there. And again, they might do MRI or CT scan. Not usually you're going to see more of a Doppler or the ankle brachial index. That's what they're going to do to diagnose peripheral artery disease. So therapeutic interventions, same thing as with coronary artery disease. We're going to try to help the overall health of the person, right? Low fat, low cholesterol diet, medications to help. Okay, Raynaud's disease. Moving on. Have I told you guys my clapping method? I do it for my husband because I want him to keep up with me when I'm talking fast. So if I'm talking about one thing and then I'm moving on to my next thing, I'll clap so he knows, like, we've left that conversation, now we move to this conversation.
Does he get mad?
No. We've been married for over 20 years. I think he's just like, this is the ride that I'm on. So anyway, moving to Raynaud's disease. You know, we're not honestly 100% sure with Raynaud's. We think it's probably some autoimmune components. It's fairly common. I usually one or two of my students in each cohort have Raynaud's or have somebody in their family with Raynaud's. So you have these vasospasms. So the blood vessels start spasming for various reasons. A lot of times it's triggered by the cold. So a lot of these patients do not like to get cold because it's painful. Women are more likely to have Raynaud's and in the cold climates, because you think about when you're super constricted with the cold, something about that makes them more likely to spasm. And if it does spasm, there's already constriction, so they're less likely to get the blood through that they need. So there's a few phases of Raynaud's. They call it blanching, pain, and reddening. I like to call it the red, white, and blue disease because that helps me to remember. So this is backwards. So red, white, and blue, and they go like, the reddening is the red, right? Pain, blue, but then blanching is white, right? So blanching is you lose the color, right? And then it starts to almost look a little blue. You're not getting perfusion like you need. That's where you have a lot of pain. That's where they have this pain, they're having this spasming. And then when the spasming stops, the blood flow goes through. And it usually goes through vigorously because it's been backed up. And it causes the hands, it's usually in the hands, sometimes the feet, and it causes like a reddened, like you see their hands turn red from all of that blood flow finally getting through. It can be very uncomfortable for patients. I know nurses who have this. So usually we say, keep warm. So these are these are patients who oftentimes wear gloves almost all the time, even indoors, because they want to keep their hands warm to prevent that constriction. Sometimes we might even give them medication to help dilate or open up the veins. And then what is so fun with these autoimmune diseases, stress can impact our body's response. So we say, control your stress, right? Because it's easy to do that. We just say, control your stress if your stress is done. Okay, so Buerger's disease, also another inflammatory disease, also probably from an autoimmune response. Usually this one is closely associated with tobacco use, okay? You have these, and it's not just the spasming, you actually have small blood clots that occur in the hands and feet. One thing they've noticed with Buerger's disease is that if you have periodontal disease or like diseased mouth and gums, that could contribute to you having Buerger's disease, which is so interesting to me because I think about people who smoke. I don't know what damage, we talk a lot about the damage that smoking and nicotine have to our lungs, but I'm also wondering what kind of damage does that have coming through our mouth too? Is there a correlation there? I don't know. I'm just curious. So you get really inflamed veins, and they had this intermittent claudication. That's where there's like intermittently, there's little clots these tiny clots that form and cause pain. And then they get cold and a little bit tingly sometimes. With this, they really struggle with getting blood flow through. And so they can start getting ulcers that form from that lack of blood flow. And sometimes it progresses where they have to have them amputated. There's no cure. And really the big thing is if you're smoking, let's teach you how to quit smoking because that's one of the biggest causes of or correlations with the Buerger's. Aneurysms. So we talk about aneurysms. It's an artery that has a weakened area. So you think about the artery being a tube, and it's like all of a sudden, like if you've ever had a balloon or something where like all of a sudden it like stretches out on one side a little bit, that's kind of what happens. The main one you guys are going to probably see or encounter or that I want you to know are AAA, abdominal aortic aneurysm. So we have our aorta, we have our ascending and our descending aorta. So abdominal is going to be the descending aorta. In the abdominal region, that's typically where we see a lot of these aneurysms happen. And it can happen over time. Usually, if you have high blood pressure, your age, sometimes there can be congenital abnormalities or trauma, but usually it's going to be age associated, along with like having high blood pressure, high cholesterol, other issues that are damaging. Oh, wow, I forgot I put a question. Okay, so if you have a patient who has a abdominal aortic aneurysm, what are we educating them to see? What are the classic signs and symptoms of an aortic aneurysm? Like that we have different answers here. All right, and the correct answer is back and flank pain. It's a little bit tricky. A lot of you guys put pulsating abdominal mass, but think about inside of your body is where is your aorta at? It's kind of more in the middle, right? It's coming down in the middle, and then all of your blood vessels are kind of branching off from it. So we wouldn't see it in our abdomen pulsing out because it would have to be like right against the skin, essentially. So we won't see it pulsing. It's in the middle, kind of in the middle of your area here. And typically when people have an aneurysm, they don't have signs and symptoms until it's late stage. And then they have some back flank pain. That's what they might see. The therapeutic you know what, this one says pulsating abdominal mass. I don't know why it has it on there because you really won't see that. So if you go back and read the PowerPoint, disregard saying pulsated abdominal mass. All right, so what do we do? So a lot of times with these patients, especially when they're elderly, we're just going to try to do damage control. We're going to say, okay, let's try to keep this thing from rupturing. We don't want it to open up. So we try to control their high blood pressure. We might try to teach them stress relief, things like that. If they're young enough and healthy enough, they might do surgery where they try to put a graft or a stent in, something to protect that area. Sometimes they might even do like an open surgical repair where they will open up the abdomen, push all the guts aside and try to repair the aneurysm. That's a big surgery though. And so typically they want to make sure somebody's young and healthy enough to survive the surgery. A lot of times these patients who have these aneurysms are not young and healthy enough to survive the surgery. So you just do damage control, meaning keep their blood pressure low, keep their stress low. All right, varicose veins. Anybody ever seen somebody with varicose veins? Yeah, usually more common in women than men, but you can see them in both. We don't know necessarily what causes them. There tends to be some hereditary things that happen. And we know that some things can contribute to them, like standing for long periods of time. But you get these veins that become kind of longer and tortuous, meaning they kind of like, oh, what's the word? They bulge out and they're like all over the place. I think I took a picture somewhere. Oh yeah. So here's a picture I pulled off the internet. I don't know if your book had a very good one. And so you can see some of these areas, both on the thigh and on the calf, where you can almost follow where the vein is at, and it's kind of bulging out at times. These are different than like spider veins. Like sometimes you see, they're not bulging out, but they're just like, you could see colorful like purple veins on people. That's a little bit different than varicose veins. So if they're purple and bulging out, that would be varicose veins. But this is what we mean with varicose veins, and they can be pretty painful for people. The blood gets kind of backed up. Sometimes pregnancy, when you're pregnant, you produce, what is it, 1.5 times the circulating blood volume than you have pre-pregnancy, because you need to supply mother and baby with all the blood that they need. So you have all that extra fluid in your body. Sometimes that can make you more prone to making these varicose veins. Signs and symptoms. Sometimes you can start with like little spider veins, but then they progress to these big varicosities. They are painful. Sometimes you'll see swelling around them. And a lot of times people they'll say their legs just feel heavy. They feel heavier. That's one of the symptoms people will say. So we try to reduce the contributing factor. So if they are standing for 12 hours a day, nurses, right? We might say, look, is there other options for you? Sometimes we talk about compression hose or stockings to help put pressure, like keep that pressure from the legs themselves. If they've already developed those big tortuous veins, they actually have some laser therapy or ablation, which ablation means they would go and essentially kill that vein because they just don't want blood to keep flowing through it. Our bodies are amazing, and we have collateral circulation, meaning there's other blood vessels that would supply all that area of the blood that it needs. But then that's able to kind of stop some of that pain from happening. Okay. Moving on. Venous insufficiency. So this is another chronic condition similar to peripheral arterial disease, but it's where you have the veins have some insufficiency. They're not able to function like they should. So it's usually the valves that are dysfunctioning, because the veins, remember, they're returning all the blood back to the heart. They don't have that high pressure that the arteries do. So those valves, right, if they start to leak or let blood come back down, it's going to pool back up oftentimes. So it could, if it's not treated, lead to venous stasis ulcers, which is usually where you see it. And so that is where those veins, after having so much back up, they kind of rupture. blood and fluid leaks out. And what you're going to see is that they have edema and swelling. It's usually kind of a brownish discoloration. It's kind of that old blood that's leaked into the skin around there. And a lot of times the skin becomes kind of hard, leathery feeling. I'm sure you can think of some grandpa out there that you've seen that has those kind of purpley dark chicken legs, right? Moving on. I know, and there's so many of these. I just want to give a brief overview of some. So lymphangitis. So lymph, right? We have our lymph system, or we have lymph nodes. This is where those lymph tracts get irritated and inflamed. I still remember when my son was really little, he was sick, and I think I was just hugging him or something, and I was around the back of his neck. I mean, he was like 4, and he had this bump about this big that sat right back here. And I was like, oh my gosh, he has cancer. You know, and I went through all these things, and I'm like totally assessing him for all of this stuff. But I ended up taking him in. I was really worried, and he was sick. And the doc was like, yeah, that's just a lymph node. It's just a lymph node that got a little inflamed, a little backed up. When he gets better, when he gets over this sickness, it'll go away. And it did. And so it happened more. My son, he's going to be this evolving case study that we have, especially as we talk about diabetes and some other things. So you're going to hear more about him. But as he grew and more things, like he would develop these lymph nodes that would get really swollen. And they would go away. It would go back down after he got well. But it was really interesting. And so with lymphangitis, it's where you have that kind of tract where the lymph flows that just gets inflamed and irritated. And so if you have paler skin, you might even be able to see it where you see that reddened area on the body. Usually it's painful. You have like that red streak, like I was talking about. And if it's severe enough, you might even need to have antibiotics to help treat that area that is inflamed. Sometimes we want to do heat, because if we can dilate that area, the blood vessels, then hopefully we can help clear some of that inflammation out of there. Blah, blah, blah. Is that the end? Oh, thank God. I was really ready to be done with that. Okay. How about let's take just like 5 minutes to reset, and then I want us to come back to our groups, and we're going to work on some, oh, we're gonna do group scenarios. Yay! Name that patient. Please feel free to grab more candy if you need another little pick-me-up, or you can do squats or jumping jacks too. I feel kind of obligated to give another option since we're talking about heart health. All right, so now we've talked about the occlusive disorders. We're going to get into the valvular and infective disorders. All right, so So things I want you guys to understand, because Davis had a lot to talk about in these chapters, and it was kind of thick. So a way of trying to condense it, I want to make sure you guys understand some. So when we talk about stenosis, stenosis is a narrowing. It's where if you have a blood vessel or an opening of some part, it is closed up. Whatever blood or whatnot is trying to get through cannot get through, as it should. Regurgitation, sometimes called insufficiency, is where usually you have a valve or something where, like, think about the chambers of the heart, right? Yeah. This is chapter 23. Yeah. Does that sound right? I think it was 23, and then we just did 24 with the occlusive. Yes, I believe 23. So insufficiency or regurgitation, that's where usually a valve, something doesn't close completely, and so then blood will leak back, or I think this should go back up. It'll leak back to where it came from. If we can remember stenosis versus regurgitation, that helps you to know what's happening. So this is some examples of a normal valve in the open position. Valves usually have, usually three kind of little leaflets, sometimes they call it, that kind of open and close. And then normally you have normal close. Here, if you have a stenosis valve, it can't open all the way. See how they're all stuck kind of and they're stiff and they're not able to open. Same way here, if a valve is like stenosed or damaged, it's causing regurgitation, it doesn't fully close like it should. So it's malfunctioning of the valve. Now, going back or clapping a little bit, I want you guys to know a little bit about rheumatic fever. We don't see it as often. You might see it more in people who are immigrants to this country, who maybe have had that before they came to the States. But it's an autoimmune reaction that happens to patients a few weeks after an infection. It's usually a respiratory infection. And they have this strep, it's a strep infection. It can be prevented. So if people are properly treated with this respiratory strep infection, you can prevent rheumatic fever. But oftentimes it's people who aren't treated promptly or treated as they should be, okay? So you always have somebody, rheumatic fever, they had some sort of respiratory strep illness, probably wasn't treated as it should. Then about 2 to 3 weeks after, they have this autoimmune reaction and their body kind of goes a little bananas. Signs and symptoms. Polyarthritis. That means like arthritis is like joint pain. So they just have joint pain everywhere. They might start getting these subcutaneous or little nodules under their skin. They might get just general feelings, discomfort, fever, pneumonitis, sometimes even carditis, and we'll go into a little bit more of these. But that I just want you to kind of remember with rheumatoid arthritis, starts as a respiratory infection. It's a strep infection, usually not treated right away. About 2 to 3 weeks afterwards, it's this autoimmune response that happens. Now, moving back to our valve dysfunctions. All right, so we have our mitral valve, which is between our left atrium and left ventricle. And then we have our aortic valve. That's between left ventricle and the aorta, right? So left ventricle, where is it sending it in this aortic valve? Yeah, out to the blood flow, the whole body, ascending and descending aorta. Mitral valve, where is this blood coming from before it hits the, right, so it's kind of coming from the lungs to the left atrium, then dips in the left ventricle. All right, so mitral valve prolapse. That's when instead of having blood, like the valve should, the valve should kind of stay closed and it should kind of open and close, right? Open and close. But with mitral prolapse, essentially it's opening and it's not closing all the way. So what's going to happen to the blood up here? It's going to be leaking down, right? It's going to be leaking. What about if we have mitral stenosis, where this valve isn't able to open or close like it should? Right, like we're not going to get the blood flow that we really need through here, right? We're going to have decreased amount of blood that comes into the ventricle, which means decreased blood flow that goes where? Out to the rest of the body. So I want us to think similarly about the aortic. Was I talking mitral? Yes, I was. Okay. Now, if we talk mitral regurgitation, again, that's where I kind of clump that in with the stenosis and the regurgitation. Stenosis is where the valve isn't opening up or closing like it should. And then regurgitating happens when it can't close like it should. And then the blood leaks down from the aorta back into the ventricle or back and forth. Aortic, same type of thing. You can have stenosis where it can't open and close like it should. It can't let blood into the aorta. And it can't close all of the way to kind of keep blood there. Or you can have aortic regurgitation, right? Where if it's stenosed, all that pressure, it can't get through as well. And then it might even kind of leak back a little bit. So that's what I want us to kind of think about. It's the valves, specifically mitral and aortic, that we're looking at. And they're either stenosed, they're closed up, not able to open very well, or they have regurgitation.
You have to worry about with regurgitation, like the cooling of the, like the blood clots forming.
Possibly, yeah, sometimes they can have with regurgitation, there can be blood clots that pool. I've lost my clicker. Okay, so signs and symptoms. There's so many signs and symptoms for all of these, but I condensed it to this list that for the most part, you see some common threads with all of these types of valve dysfunction, where a lot of times you have no signs. There's nothing that we can see, hear, or feel with them. But occasionally there might be some murmurs, right? Because what is a murmur telling us? It's turbulent blood flow. There's something that's happening, like it's sat, like blood flow isn't happening normally. And so you can see if there's stenosis, if blood's really trying to push through that tightened valve, or if it's prolapsing, how that would give us that sound of the turbulent blood flow. There could be dyspnea, right? Especially if it's affecting that mitral valve, right? We might have some blood backing up into the lungs. They might have fatigue, occasional syncope or fainting. They might have palpitations or arrhythmias, right? As the heart muscle is working really hard, these patients might develop some arrhythmias. And I want you to remember, it kind of depends on where the valve is at, what some of the signs and symptoms are, right? If we remember our anatomy, just like right and left-sided heart failure, if we can remember the blood flow, then knowing where that dysfunction is at kind of lets us know where's the blood flow not getting to, or where's it getting backed up to. All right, so diagnostic test. Well, if we hear a murmur, that gives us an idea there's something going on. We might do an electrocardiogram. There might be an altered heart rhythm. They probably want to do a Doppler echocardiogram, which Doppler, we talked about like a Doppler ultrasound for your leg. They can do Doppler echocardiogram, which is ultrasound of your heart. And they're able to look at the different pieces of the heart, the different chambers and the different valves that are in the heart with that Doppler. If the Doppler kind of shows something and they're not sure, sometimes they'll do a transesophageal echocardiogram, which they do this big scope and they go down in your esophagus because your esophagus sits right behind your heart. So if we do the Doppler from our chest and we're looking through, we'll have to look through all the muscle and the ribs and the bone that's there. It's harder to see. But if you go down your throat, there's nothing really between your heart and your esophagus. And you get this beautiful, clear picture. But it's pretty uncomfortable, right? People having to swallow this tube. They're usually sedated, like not surgery, like anesthesia, but like for a colonoscopy, like a conscious sedation. But they give good pictures. All right, so therapeutic interventions. If somebody has a disorder of their valves, what do we do? Well, just like sometimes there's no symptoms, if there's no problems, if it's not causing an issue, then we wouldn't have to treat it, right? Our bodies are so good at compensating, making up for things that aren't happening right. If they're tachycardic, if the heart rate is high from what they're doing, we might give them beta blockers that might help lower. If the blood is getting backed up, we might give them some diuretics, similar to what we would do with hypertension, where we're trying to lower that pressure. We want to give anticoagulants to try to prevent thrombi, right? Especially if it's stenosis and that blood is kind of getting backed up and not flowing like it should. And then there's also some transcatheter surgeries. We talked about the cath lab earlier for coronary arteries. It's kind of similar in what they do, where they would go in and they access actually inside of the heart through usually the femoral artery. Sometimes there's radial or brachial. And here you can even see, well, this kind of shows you this, I kind of like this picture because it shows you how pieces of the heart, you have these fibers that actually help you open and close. They're not just magically like floating open and close, but you have these heart muscle fibers that help the valve open and close. I'll talk about the valve in just a second. Okay, well, let's go back here. They have surgeries if your valve is stenosis. Similar to the cath lab, when they would go to a balloon angioplasty and stretch open the coronary arteries, they can insert a balloon in here to try to stretch open the valve, see if they can get more give or have more give to it. Sometimes they can't, and they need to do eventually a valve replacement. Anybody seen in clinicals yet somebody that had a valve replacement? You did?
My husband actually.
Oh, does he? Have you listened to him?
Yeah.
What does it sound like? Yeah, yeah. So anytime you have somebody that has an artificial valve, normally we hear lub dub, lub dub, lub dub. That's what we hear. We actually can hear these artificial valves. So depending on where it's at, but you usually hear lub click, lub click, lub click. Sometimes even from the door of the room, you can hear it.
With like, okay, because he has a mechanical valve,
Mm-hmm.
but some people have like pigs, or, you know.
Exact. So great question. No, with the pig valve. So with a mechanical valve that's made out of synthetic materials, that's when you hear the click. There are valve replacements that we do. Did I skip over all of this? I'm certain I talk about it somewhere. Anyway, so there are like pig valves or the other animal, cow. Sometimes they'll harvest those valves from cows or pigs because their anatomy is more similar to ours. And so they'll transplant that into our heart. Why could that possibly be an issue for some people groups? Yeah, yeah. I can think of people, if they are Jewish, they probably wouldn't want to have a pig valve inside of them, right? That would be something that might be an issue. Or people groups that have beliefs about cows, right? They might not want to have a cow valve in them. So we just need to be aware of that because they might say, I'd rather have the mechanical valve. The mechanical valves, those do typically have to have anticoagulants because there's more risk of bleeding or blood clotting, excuse me. The pig valves or the cow valves, generally you don't have to have anticoagulants, but sometimes they do have them on like an immunosuppressant, so their body doesn't kind of reject the valve either. Where are we at? So the nurse collects data on a 72-year-old female patient with aortic stenosis. Which sign and symptom to the nurse indicate to the nurse obstruction of blood flow to the myocardium? I feel this is probably a select all that apply that won't let you actually select all. So, you guys, so good. Chest pain and arrhythmias, right? That's what's going to indicate to us there's something actually happening in the heart. So, types of surgery. They try to do minimally invasive, meaning if they don't have to actually open your chest and do surgery inside, tinkling with things, they try not to. They'll try to do endoscopic surgery, sometimes with like a catheter, where they just snake a catheter and do what they can through there. It just depends. Traditional approach was open cardiac surgery with bypass, meaning open cardiac surgery, open heart surgery. That's where they say crack the chest. Sometimes you'll hear that, but that's where they actually will open up the rib cage and access the heart, like with an open incision. So look at your patient's chest. If they have a big scar right through here, it usually means they've had open heart surgery. Used to be a lot more common, But as we've advanced medicine, we've discovered we're able to do these less invasive where we can go through catheters or kind of smaller incisions where you don't have to completely open the chest. Types of repair. So if the valve is stenosed, like I said, they want to kind of go open it up. If it's insufficiency, if it's regurgitating, they might have to go kind of do a replacement or sometimes they can actually shave off pieces of the valve. Here's the picture I was looking for earlier. So if a valve is stenosed, you can see they took one of those little long balloons and they're just going to blow it up and try to stretch out that area that's all closed up and hopefully get better blood flow through to the heart. Really? I mean, they probably, if you opened it up well enough, I can see where it might have some regurgitation, but my guess is it probably already had some regurgitation if it was already so stenosed. And the goal is to let more, just try to get more blood flow through. Here's where we talk about the mechanical. They're more durable, but because they have more turbulent blood flow, they need anticoagulation for life. The biological, oh, here we go. Oh, I didn't mention allografts, which is just, right, like a donor or cadaver valve. Do you guys know you can donate like just valves like after you pass away? Anyway, they're not as durable as the mechanical valves, but like I said, they don't have to have the anticoagulation for the rest of their life. One of the things I want to make sure we know is that with these mechanical valves, because they have the risk of blood clots, we want to make sure we're teaching our patients to monitor for signs of bleeding. And if they're on warfarin, we're usually getting their INR monitored for bleeding risk. All right, so clap, clap. Now we're going to move on to infectious and inflammatory cardiac disorders. So I wrote out this little piece of the heart. Again, Davis had so much on this. The pieces that I really want you guys to understand are kind of the anatomy, where you have on the heart, you have the endocardiogram. That's the inside layer of the heart. The myocardium, I remember like myocardia, the muscle, like that's the inside layer of the heart. That's the muscle. And then you have the pericardium, and that's the outside layer of the heart. So I know that's going back to anatomy and physiology, but it makes a difference because we can have inflammation and infection of all of these different layers, and sometimes it looks and has different treatments for them. Okay, so endocardium inside, myocardium, the muscle, and pericardium is the outside. So infective endocarditis, right? So we can word build if we're like, oh gosh, what's that word? Endocarditis. Endo, where's that at? Inside the heart. And it's itis, it's inflammation of it. And it even says infective. We know the inflammation is from an infection. So one of the things is that a lot of times we see bacterial infection of some part and it's flowing through our body. And these bacteria will come and attach themselves to the endocardium, the inside of the heart walls. It can actually also form on their leaflets, on their valves as well. You can see it kind of attached all through the heart. So risk factors, if they are immunocompromised, IV drug use, gingival disease, those are all ways that infection can enter the body, right? You think about if you have a tooth that's not doing well, right? It could get infected, and that infection can easily get into our bloodstream and travel through our body and grow in the layers of our heart. That's why we're so big on making sure people have good dental hygiene and treat those things. Also with IV drug use, I've seen a lot of patients with IV drug use have infective endocarditis, right? Because they're not careful with their needles they use, sterility, and as they're using IV medications, they introduce bacteria and pathogens that end up going and kind of growing into their heart. Prevention is key. Oral and dental care is also a big part of the endocarditis. Signs and symptoms. right? So just like infection, we're probably going to see a fever. That's just a general infective response. We might have murmur or petechiae. Here's petechiae. This is what that looks like when you see your patients. They're little small red dots. They're not raised, so it's not above the skin. They're just flat surface on the skin, but this is what petechiae looks like. So complications with infective endocarditis, sometimes you can have, it's called a vegetative emboli. So and so this will just be with the endocarditis because this is the inside layer of the heart. That's where all the blood is forming. And if you have this bacteria that starts growing into this layer of the heart, it can kind of create like a little lump of bacteria. And if that lump breaks away, it can travel through, probably go to the lungs first, and it creates a clot, essentially. It's not a blood clot. It's a, what do we call it? Like a vegetative clot. So a infected clot. And it can go and block up blood from getting through to the lungs. So that is a complication. Diagnostic tests, well, we do blood cultures. We want to see if something's growing in their blood. And then the echocardiogram, or usually I'll see the TEE, the transesophageal echo, yeah, I'm saying that right. So when they go down the throat and look at the heart, that's where oftentimes you can see the growth on the valves or inside the heart. You can see those vegetative growths. So what do? We give them IV medications, IV antibiotics. Do you know how long they have to be on IV antibiotics for? Did you? Well, good job finding it in the book. Want to say it for the class? Yeah, 6 weeks. I know at a unit I used to work in, they used to have patients who would be often admitted to the hospital because they normally, if you're like a regular patient, you can do your antibiotics at home. They can put PICC lines in, and you can either go to infusion service or they can teach you how to do it at home. But if you have history of IV drug use, they do not usually feel comfortable letting you go out into the community with a direct line like that, right? Because the risk is that you might use again and try to use through your line. I've had patients in the hospital that have done very bad things to themselves by trying to inject drugs from the outside through their PICC line while at the hospital. It's crazy. So these patients who have history of IV drug abuse and have infective endocarditis, a lot of times they stay in acute care at the hospital because we can't trust them to go out in the community with an IV line, especially a central line that goes to their heart. So long time. Nursing management, we really want to teach them about, depending what the cause was, if it was IV drug use, man, let's talk about how do we get clean? How do we have some rehab? If it's poor dental care, maybe we talk about, hey, like if you start having issues, we got to get you seen right away. We've got to get you into clinics. We can treat these things before they become an issue. Okay, so scenario, you're caring for a 78-year-old male patient with endocarditis. He lives alone and he self-catheterizes for a neurogenic bladder. Excuse me, that's our scenario. Which of these should the nurse reinforce for discharge teaching? Do you want him to eat lean red meat, maintain biannual dental cleanings, apply lotion vigorously to the calves, or wear compression stockings for 1 month? Oh, you guys are so good. Dental cleanings, right? All right, so pericarditis, right? Our pericardium is the outside line of the heart. That's when the pericardium gets really irritated. So what do we see? A lot of times it's chest pain, right? With the endocarditis, we don't really have pain from that inflammation. It's more just general fever, malaise. They don't feel good, but they might feel specific chest pain. And sometimes you can hear a friction rub. We're probably not at that point in our assessment skills to be able to hear that yet. But if you ever have a patient with pericarditis, go listen, go see what you hear if it's different. A lot of times they can have dyspnea or a cough. So what do? Sometimes we want to treat the cause. But if that pericardium is inflamed enough, it can kind of push in and restrict the heart. That's that inflammation. It's almost like it's encasing the heart, keeping it from beating as it should. So one of the things they might do is a pericardial window or a pericardial centesis. I don't know how well you can see this, but here's the picture of the heart. And normally the pericardial sac is just like right up against the heart. But if you have pericarditis, you can have fluid that fills this sac. And so they might go in and with a needle, it's crazy, and they would pull that fluid out. Now, of course, this would not be a nurse. This would not be us. This would be a specially trained provider. If you work in an emergency room, you might occasionally see this. Typically, they would use ultrasound, right? They use ultrasound and they could see that pericardium is enlarged. And then they would use that ultrasound to help guide their needle in to make sure they don't puncture one of the chambers of the heart, right? But once you relieve that pressure from the pericardium, it really can relieve a lot of those symptoms that the patient has. Super interesting. So pericardial effusion, that's what happens, like what I just showed you in this picture here. Not all pericarditis forms a pericardial effusion, but this is what could happen with pericarditis. Does that make sense? I don't know if I differentiated very well. So you can have the inflammation, but doesn't cause the fluid around. The fluid, if it forms, that's called a pericardial effusion. And you can have what's called cardiac tamponade, and that's where that fluid, that's when it's pushing in so much on the heart that the heart can't beat like it should because there's too much pressure from the sac. That's when you would need to do a pericardial centesis and pull out that extra fluid. Okay, so we talked about the inside of the heart, we talked about the outside of the heart. Now we're going to talk about the muscle layer of the heart, myocarditis. So that's that inflammation of the myocardium. I'm not going to spend a lot of time on it because it's pretty rare. Normally, if you have patients with some sort of infection or inflammation of the heart, it's going to be the endocarditis. That's what you're mostly going to see. You might occasionally see pericarditis. You probably won't see myocarditis. It's usually after some sort of virus, some bug, viral infection. Remember, endocarditis is bacterial infection that usually ends up sticking to the heart. Myocarditis, it's usually a viral infection, and that's what goes in and kind of builds inside the heart muscle. You can have chest pain, tachycardia. Usually, what we try to do is treat the symptoms of what's happening and the cause. So if we can give them an antiviral to help decrease that virus, or we can give them, if it's starting to cause some heart failure issues, we give them medicine for that. It's usually symptomatic type treatment. Oh man, we're almost done. I'm going to skip over cardiomyopathy. I feel like it's kind of dense. What I want you guys to know is that you have your heart muscles, right? Cardiomyopathy is where you have there's dysfunction. Like in this first one is normal. The inside, the colors, the red and blue, that's the inside chambers of the heart. The outside kind of pink color, that's your muscle. With dilated cardiomyopathy, that's where the chambers are enlarged and the muscle's still kind of thin. Like the chambers are just getting bigger, trying to be able to hold more fluid, more blood. Hypertrophic cardiomyopathy is this third one. And that's where we talked about, I think last week, when your muscle is like pushing so hard that the muscle ends up growing large. And hypertrophic, see how it's kind of compressed or pushed down the actual inside of those areas of the heart, chambers of the heart. And then restrictive cardiomyopathy, it kind of looks similar to the hypertrophic, but with restrictive, it's actually that the muscle itself is kind of stiff and it's not able to compress and contract like it should. Look over cardiomyopathy. I'm probably not going to ask you a lot about it on the test. So boop, 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 boop. Okay, here we go. Thrombophlebitis. So I do want to make sure we understand. We talked a little bit about like arterial issues with arterial clots, but I want us to know about thrombophlebitis. You probably will see this in your patients. Thrombo, it's a clot, phlebitis, inflammation. So usually it's either in superficial or deep veins. Deep veins, deep inside your body, usually in the legs. Superficial veins, more close to the surface. Kirkchow's triad, it just means like if you have these three things at risk, you're very likely to form a blood clot, which is venous stasis, meaning reduced blood flow, damage to the vein lining, which can happen with IV insertion or trauma, and increased blood coagulation, right? So if you're dehydrated, you smoke, any of those issues. So if you have those three factors, you're at very high risk of forming a blood clot. Prevention, right? We want to keep them hydrated. We want to keep them walking. We might put STDs on them. Blue, 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 blue. Complications, if you have a complication, right, that the blood clot might break off and travel. Usually, if you think about a blood clot in your leg, it's going to come up through the superior vena cava, right? Or inferior vena cava. And then once it goes to the heart, where's the next stop on the heart? Into the lungs after, like right atrium, right ventricle to the lungs. So oftentimes when we have somebody that has a pulmonary embolism, it's because they had a blood clot in their legs that broke off and traveled to the lungs. Boop, boop, boop. We would do a D-dimer test for them. This is a marker in our blood that says, yes, they are at risk or probably have some sort of clotting issue. Boop, boop, boop. If it's a superficial clot, we're going to do some warm packs. We're going to give them some pain medicine. We might give them compression stockings. But if it's a deep vein thrombosis, we're going to put them on some blood thinners, make sure they don't form any other clots. They might do thrombolytic therapy, not as often as if it's a clot in the heart. But we also are going to be trying to elevate the leg to decrease swelling. How about this question for you? A nurse is caring for a 42-year-old patient who is a pilot with a history of varicose veins. Which of these signs and symptoms do we say report to the healthcare provider immediately? Which ones that reflect a life-threatening condition? And I think some of this too, it's thinking back through with what we learned about varicose veins, right? They get enlarged, tortuous. The blood probably doesn't flow as well through them. And if the blood's not flowing well through, what could it form in those varicose veins? It could form a clot. So what it really is asking us is, what are signs of a blood clot in the lungs? Sometimes it's also called pulmonary embolism. So that would be dyspnea, difficulty breathing, hemoptysis, coughing up blood, or tachypnea. What's tachypnea? Fast breathing. Good job. All right, what about this one? Mrs. Stecker is an active 27-year-old accountant. She comes into your clinic with reports of right leg pain, redness, and edema. During your data collection, she reports smoking cigarettes, having a sedentary job, and eating 2 healthy meals a day and exercising 3 times weekly. She states she takes a multivitamin and oral contraceptives. She's married with 1 child, and she gets diagnosed with a DVT. So, which of the following do we think contribute to her plan of care? Wait, never mind. It says, which of the following does the nurse contribute to their plan of care? Do we want to encourage early ambulation, demonstrating coughing and deep breathing, massaging lotion on both legs and feet, or measuring leg circumferences, and the same in the both legs? Yes, we want to measure the leg circumference, right? Because we know the deep vein thrombosis, and it said that her leg is swollen. We want to kind of measure how much more swollen is it, and then we're going to remeasure probably every shift and see if it's getting worse or getting better. With Mrs. Strecker, Which of these data points do we identify as being a high risk factor for thrombophlebitis? And again, you probably can only choose one, but just choose one you think, and then consider the rest. All right, so yes, sedentary job, smoking, and good job, the one person who chose oral contraceptives. Women who are on oral contraceptives, when we're shifting our hormones around, that does make you more likely to form blood clots. What about these do we reinforce with Miss Strucker to help prevent a deep vein thrombosis? Do we want her to take multivitamins, avoid stress? Wait, avoid exercise, manage stress, avoid extended periods of sitting or standing, and maintain hydration. And well done. We want to keep her from standing or sitting for a long period of time, and we want to keep her hydrated. Oh gosh, the end. Okay, everybody stand up. I'm going to go through a few quick questions with you. We're going to get a little bit of a last man standing just to kind of try to sink in all of this information. I know, you guys are hanging with me so good. Okay, so if we have somebody with a myocardial infarction, what do we anticipate implementing? Do we want to adjust the bed to Trendelenburg position? Maintain prescription of complete bed rest for 5 days? Provide clear fluids throughout the hospitalization? Or administer a stool softener to prevent straining for bowel movements? Do you guys know what Trendelenburg is?
Isn't that weird? Like,
It's where if you say your bed is flat, and if this is the head, you drop them on their head. All right, well, and the answer is stool softener. Good job. I said it in the lecture earlier. When somebody has a heart attack or a myocardial infarction, we don't want them to strain because it's going to put pressure on the heart. All right, a client's diagnosed with varicose veins and they're reluctant to have surgery. She asks what she can do to help reduce the pain. The nurse suggests engaging in 30 minutes of aerobic exercise every day, wearing knee-high trouser socks, avoid sitting or standing for long periods, or riding a stationary bike each day. All right, we've got herd mentality going on. I see a lot of C. You're right, avoid sitting or standing for long periods of time. A client presents to the emergency department with complications of syncope, which is fainting, and chest pain. The EKG results indicate the client has supraventricular tachycardia. The nurse anticipates treatment of this dysrhythmia being, I know we didn't even cover this in class, it's extra credits. Digitalis, lidocaine bolus, pacemaker insertion, or Coumadin or daily aspirin. Oh, Elizabeth, are you just sitting down? It's like I give up. So if you have syncope and chest pain and the EKG is really fast, supraventricular tachycardia. All right, I'm going to say final answer is digitalis. So we didn't talk about it, but that's one of the things it can do to slow the heart. So you guys were on pacemaker insertion. So let's talk about that really quick. If the heart is beating really fast, what would a pacemaker do for it? Not really anything. It's when the heart rate is really slow, super slow. Then we would have an internal pacemaker that would be placed, or short-term pacing to keep the heart beating fast enough. All right. A client's experiencing premature ventricular contractions and reports a fluttering feeling in the chest. The nurse explains the cause of the client's symptom as the ventricles are beating very fast, 150 to 250. The ventricular contraction occurs early and independently. C, it's the rhythm of a dying heart. or a single atrial impulse outside the SA node causing the atrial contract. Is it just you two left?
No, we all.
Oh, you all? Ah, do you guys remember what a premature ventricular contraction is? B. It's B. The ventricle contracts early and independently. Let's look. Okay, that was about it. All right, thank you guys for sticking with me. Again, this material is thick with content. Don't forget to fill out your KWL. And week is at 5. Yeah, that's it. Have a great rest of your week.
Next Tuesday for a worker training.
So let me know how to do it, great, because